so this next case, a 70-year-old woman. She had a hemithyroidectomy for benign disease many years ago, and over the subsequent couple decades, an enlarging left-sided thyroid nodule, which caused progressive dysphagia and pressure symptoms, became quite symptomatic with this. It's been biopsied many times as benign, and here you can appreciate this large left-sided nodule. This is her ultrasound. So longitudinal image shows the majority of the left lobe occupied by this nodule. Maybe just a sliver at the upper part of residual thyroid parenchyma. And you can see on the transverse image that there's the contralateral right lobe, of course, is entirely missing after hemithyroidectomy. The nodule volume was 75 cc's. And so really this became a discussion with the patient of what are we trying to accomplish here? As Jen Kuo said, many patients, the motivation is to avoid being on lifeline thyroid supplementation, medication, and in my opinion, just because of the extent of this nodule occupying the majority of the left lobe, there was a higher than normal chance in this patient that it had a right hemithyroidectomy. So her goals primarily were to avoid surgery. She didn't want to have another surgery. In fact, she regretted the first surgery that she had. The second goal was to improve her symptoms, and she was okay with the risk of becoming permanently hypothyroid, although of course she wanted to preserve thyroid function if feasible. So with that in mind, and after a discussion of sort of her symptoms, we decided to proceed. And based on her goals and also the nodule size, I did this as sort of a prospectively staged approach. So what we did initially was target the upper pole of the thyroid nodule, and then paused to see if her symptoms had resolved and what her thyroid function had done, and found that the upper pole, responded nicely, but the nodule itself overall, including the unablated lower portion, the overall VRR was 22%, but she had a pretty good improvement in her symptoms. Her thyroid function at this point had not changed, and again, after discussion with her, she wanted to continue. She was very happy with the results, but thought maybe we could do a little bit better. So we brought her back, we targeted the lower pole. This is what it looks like 18 months after both of those ablations. Overall volume reduction ratio of 83%. She had complete resolution of her compressive and dysphagia symptoms. And her thyroid function throughout this process remained stable. The two green arrows are the two ablations, her TSH. She did have this little blip, which I can't account for, but since then has reverted back to normal. And so really her TFTs have not changed. So anyway, I thought this was interesting, and did look in the literature in patients that have had prior lobectomy and contralateral ablation. And the same experience, this is a paper by Dr. Douek and colleagues, were 11 patients who had hemithyroidectomies. Also, after contralateral ablation, they remained euthyroid. A more recent paper, similar results, 20 patients, hemithyroidectomy, contralateral ablation, still remained euthyroid. So anyway, I think it's interesting. I think it's interesting how little ablation can affect thyroid function, even in a patient with seemingly such little reserve. I don't know if you have any comments or anything to say about that.
Some question. In our experience, it's the same.
Yeah.
In our experience, we have 55% of patients who have thyroiditis. Sometimes what happened that the TSH went up is because there was a PTPO positive sign. Otherwise, it's true. It's incredible that nodules don't produce nothing.
Yeah.
So you cannot blame them, but they do nothing.
Yeah.
Functionally, yes.
Yeah, question.
I have a little unrelated question, but when you, thank you. So it's a little unrelated, but when you showed the post-ablation pictures, it seems like there were some small nodules that were not seen on the ultrasound.
Yeah.
And did anybody, so I see the same thing, especially for our nodules,
Yeah.
like them, and wondering if there's any literature on that, or what shall contributions psychologically to make that.
So of there being residual nodules. maybe-
Right, that we're now seeing at the time of the deletion, because I
Oh,
think.
yeah, it's a good point. There are these two sort of isocope nodules, or maybe they're components of the nodule that went unablated. You know, in this case, these were small, these were Thyroid 3 nodules. We continue to watch them, and they've been stable over that time. I mean, I think the other interesting thing is it looked like it was a tiny sliver of normal parenchyma, but perhaps it was really compressed. So maybe there was more parenchyma reserved than I thought. And I do see that sometimes, you know, after ablation, there's more thyroid, normal thyroid than you'd expect. Thanks. Yeah.
Thank you very much. I have a similar, but a little bit more complicated. The patient had bilateral surgeries for multinodal goiter, and looks like one side was quite subtotal, that now she had about 5 centimeter nodule where supposedly indeterminate thyroid and symptomatic. And she would like to avoid another surgery.
Yeah, and what's her thyroid function? Euthyroid?
She is on small dose of thyroid replacement.
Yeah, so Dr. Beck or Dr. DeAndrea, so a recurrent nodule within a patient that's had bilateral, presumably partial thyroidectomies.
So surgery versus RFA.
Surgery versus, additional surgery
I would
versus.
say it's a primary indication
Yeah, it's a great indication. You're not gonna, especially because the patient's already on thyroid supplementation, so, and I think it can be quite effective. Yeah.
Yeah, she's interested in RFA, so
I think it's a great candidate for it.
thanks.